going to talk about challenges in total knee, and for the panel, there's no tricks. The cases are not like there's no real nuances here and making you look sort of not good on the panel. So my point is to try and get through a lot of points quickly. So if you blab on too long, I might cut you off for that. That's about it. Okay. All right. So 65-year-old male bilateral medial knee pain. All right. So those are the radiographs. So nothing crazy, but bilateral disease. So let's talk about a few things. So what pre-op films and planning do you do? So Tom, routine case or OA, yes. What are your pre-op? You should use the mic so everybody can hear you.
So AP, PA 45-degree view, sunrise view, and laterals 90-degree flexion.
And do you get hip to ankle?
If I'm going to operate on them.
Yeah. If you're going to operate, it's like part of your plan.
Yeah. Long leg film, always.
Hip to ankle?
Yep.
Yes. And you do it. Anybody here not do hip to ankle? Yeah, so quite a few. Do you think you need to do it for everybody or not? What do you think, Greg?
Yeah, I do. I'm not quick enough in clinic to get their whole surgical history, and I can tell you I've been fooled a lot of times where they have a deformity or something that I didn't know about.
So Derek, he put up his hand, he doesn't do it. So is he just wrong?
He must be lucky.
Well, I mean, okay, so on average, you could probably get away with it, but it's a simple film to get. You may discover they have some hip OA. And so to me, it's just part of rational planning on the case. I can't see why we've gone away from it.
And Derek, why do you not do it?
Yeah, so some of it's clinic flow. One of our biggest clinic flow issues is X-ray backup.
Can you guys hear him at the back? Got it. Yeah, sorry to peg you, but I'm going to...
One of the issues is clinic flow. So our X-rays are probably our biggest clinic flow backup. I share.
Ours is horrible.
I share clinic space with spine providers and physiatrists and everything else. And so when people get backed up an X-ray, it's waiting for that X-ray. So for them to take the 3 cassettes and then sort of stitch it together, we don't quite. That can cause some clinic flow backup issues.
Okay.
So that's sort of been honestly the biggest reason. The other reason when we looked at it a little bit too is there's a difference in charges for the films.
You get charged for what's it?
Yeah, so some insurers will charge more for the hip to ankle films for the scanogram than they will for the regular knee films, and we've had some sort of insurance denial issues and some patient charge issues with that. Now that being said, I think it's great to do. I think that maybe if we sort of standardize our practice, maybe we'll all sort of go to it. But again, honestly, it's a logistics issue more than anything else.
I get that. Our patients wait, without exaggeration, about an hour to an hour and 15 minutes in an X-ray routinely. And then they wait another 2 hours to see me. So they're really happy, let me tell you. And then they wait 18 months for surgery. So it's great. Our system's fantastic, really. You should adopt the Canadian healthcare plan. Absolutely. So anybody here plan in terms of taking their X-rays and looking at things specifically? Okay, so Tom, take me through. Tom.
Yeah. So the first thing I do is figure out my cut on the long leg film. I'd use it for...
Your tibial cut, is that what you're saying?
Tibial and femoral.
Femoral, okay.
And I do it because I want some sort of like eyeball guess to make sure I'm close.
Okay.
Now you can say, well, the film's rotated, what do you get from it? Okay.
You draw a line, you're 90 degrees, so you kind of know what, and so you can sort of reproduce that in your mind.
Right. Now, am I generally going to deviate from 5 degrees valgus on the femoral side? Probably not, but occasionally I have.
So who changes their distal femoral cut depending on X-rays? Wow. That's quite a few, actually.
That's interesting. Me and my partner published in JOA about 4 years ago on that concept, and what we found was that customizing your distal femoral valgus cut made really no difference in your overall ability to achieve a neutral mechanical alignment.
Well,
it was the
partly
tibial cut.
True, don't you think? It's also because when you customize it, you're doing a degree or two, and we're not that accurate, right? So,
yeah.
I mean, if you customize it and range from 3 to 10, you probably might make a difference. But I used to go 6 degrees everybody, and obese patients 5, and I'm like, that's just stupid. I mean, 1 degree, so I just set it for 5 for every single person. I don't ever change. But the tibial cut, I think, is a good, especially if you're training people, get used to that 90 degrees, so that's what your tibial jig should look like.
Yes.
Everybody kind of do that? Yeah.
Right.
Okay. So pain protocol, anything you want to share that you think is really important in your pain protocol? Mic's open.
I think the most important thing to me in my pain protocol is TXA, and I know that sounds weird, but it's just the bleeding into the tissues is what really causes the pain. But I do think that blocks are also important. So I would say those two things are the things that I would think.
Everybody injecting some cocktail one way or the other?
Yes.
Anybody in the audience not injecting their knees? There you go. So that's kind of, Tad, you're not? Oh,
I am injecting the knees. One thing that's come up recently that makes a lot of sense to me is this: take some of your injection and put it into the adductor canal. You know, we're using single shot now adductor blocks, and so maybe it's not as critical in that setting, but you have access to that from the joint. We talk about putting a little bit of stuff here and there all around the joint, but you know, maybe the adductor canal is another thing to look at. We have access readily from our operative field.
okay. Who, show of hands in the audience, how many work in an institution that you have a block room or pre-op anesthetic room? Show of hands. All right, so that means everybody else, they're farting around in the OR, trying to get the spinal, doing the thing. No, so your spine, they come in spinalized already for most people? Yes. Anybody in the old system, so you're shaking your head, so you get tortured then. Every patient comes in, they can't get the spinal, you're watching them, your blood pressures, that's your system? Yeah. Well, see, if you got hip to ankle views, that would go away.
Maybe
Yeah,
if
so that-
anesthesia looked at those.
I mean, I
and-
got to tell you, that was the biggest game changer for us when about 4 or 5 years ago. And so it's actually way better for anesthesia, too, because they can teach their residents and their fellows in a non-threatening environment. Not that I'm threatening, but I can be if you waste too much time. And if they can't get the spinal, we know, and so they bring them right into the OR and they're doing a GA. Well, fair enough, you know, and the 5-10% of the time they can't quite get it or it hasn't worked. So it's just been a game changer for our lives and turnover in the room. Did you have a thought there, Tom, or no?
No, it's just,
You guys should push anesthesia on that one. You got,
so,
Yeah.
so anesthesia in my hospital claims it's not safe, but luckily,
anesthesia as a concept or what?
well, that too, but doing the spinal outside of the room, non-monitored. But luckily, we've got a good cohort of people. So for 7 o'clock roll in, spinal's in, we're cutting skin at 7:35. So I don't have that kind of lag because I'm not at a university.
Oh, that's good. Well, I don't ever start cutting before 8, but it's between cases. Literally, it's, you know, it's about 17, 18 minutes for patient out, room clean, next patient in, and that's a pretty good turnover for a total joint room.
Right.
Okay, anybody in the audience doing unis? Show of hands. Every now and then. So that's good. That's more than half. Anybody on the panel not do them?
I do maybe 2 or 3 a year.
Right, so.
So that's kind of the
Is that
worst thing to
enough?
do, right? The 2 or 3 a year thing?
Self-admitted, yes.
What?
And I bitch to myself every time I'm doing one.
Why do you do that? That's kind of stupid. Why'd you do that? No, really. Do you not have a partner that's interested in you can just lateralize, or you don't do that?
No. One of our junior partners, we're hoping he gets some interest in that, and we can
Can't you just
make
make 'em,
him
or-
the uni guy. My other partner, no, we're the same and don't really enjoy them, but for patients that are demanding it and are appropriate candidates, we'll do it.
Okay. Our shop, we have 2 guys that do it, and 4 of us don't, and that seems to work best, you know. So they're each doing 30-ish, 25 to 30. So I think that's decent. I mean, anything's hard to do just once or twice a year.
Yeah.
Right? I know you were telling your wife that last night.
I think
So,
there you go. There was a good article a few years back about the number of unis you have to do to stay current. And
Yes.
It's really 10 to 12.
Right.
So you gotta do one a month.
Yeah.
So I'm considering giving it to my.
Is that what you do?
partners.
Or no?
Mine
Okay.
per year. Oh.
Enough of that. So,
No,
show of hands in the audience. What's your go-to knee? How many CR? PS? And anybody go-to mobile, whether it's CR, PS, mobile? Not, one or 2. Okay. What? Revisions, yeah. These are, just for primaries. Guys, anybody have a strong feeling what we should be doing bearing-wise? Good, because there's the literature registry showing almost equivalence, other than, I do a PS for everybody, but most registries will show PS has a slightly higher revision rate, and then the PS guys are like, well, they're not exactly the same cases. You do your tougher cases with PS, so we don't know for sure, but there may be a slight difference, but less than 1% difference at 15 years cumulatively. Resurfacing the patella. How many in the audience, every case? How many selective? Okay, I'm selective. Anybody never? So that show of hands is completely dependent on where you ask that question. You ask that question in parts of Europe, it's like 1% resurface, 99% non. The US is about the highest resurfacing rate in the world right now, but anybody have strong thoughts on resurfacing the patella one way or the other?
Well, I used to, just because I thought with the implant I was using,
Yes.
that it would be a better thing to do.
Uh-huh.
And other than some patellar crepitation and some clunk, I said, what's going to be the downside? And it's not greater than 2%, it's much lower than that. But the downside of not resurfacing is at least a 2%. You got to go back in and resurface it.
Yeah, the downside is you're
So-
looking at the x-ray, they have anterior knee pain, and you think, well, okay, should I go back and resurface that patella?
Now that you've convinced me to do something else, I've just not resurfaced my first patella ever in 24 years. And if she straightens her knee out and screams, it's called the McDonald's sign. So I'll let you know. I'll see her in 4 weeks.
There's so many things I could say, but I don't know everybody in the audience, and I don't want to get written up. Okay, so it's dealer's choice. The Australian registry is great, and it breaks it down, and it made it very clear it's implant specific. So there's some implants where the going back revision rate, not resurfacing is the same, but then there's others, like the implant that I used previously was a non-patellar friendly implant. I resurfaced every single one because it wasn't an anatomic femur. So your femur or your patella is, and it was into just a U shape. That's gonna have point contact loading. Alignment goal. So who here puts their knees in on purpose, wrong or crooked?
Define.
So one. Yeah, well, you're gonna go home
What do, you,
cementing.
what do you mean by crooked?
Like not a neutral tibial cut and 5 degrees distal femur. Anything short of that's wrong, right?
No, I think you got to go somewhere in between. Now, come on.
Yeah, I think that's, so.
Okay, so well, I'm trying to get things going here, so yeah.
You're boring.
Challenge me.
So to me, the alignment goal, and I didn't get to ask Stefano about this, but the unhappiest kinematic aligned knees I've seen are people left in valgus, who were originally in valgus. They all complain of medial knee pain. That's been one of my best revision practices. So for me, it's 0 to up to 3 degrees of varus.
Okay, so and on purpose then, do you navigate, use a robot? How do you know you're dialing in 3 degrees?
Because I do. No, okay.
Okay.
So.
I'm already questioning this now, so how do you know?
No. So the honest answer is, there are people who have always been in varus, right? It didn't come about as part of the deformity. You ask them, in high school, were you a cowboy, cowgirl? Yes. So actually, for those people, I do navigate.
Okay.
And I'll leave them between 2 to 3 degrees
Fair
of
enough.
varus.
So if you
and
navigate,
those are the
you can
ones I
dial it in.
navigate.
All right. So anybody here drifting their tibias up to 3 degrees in varus on purpose? Yeah. You just yourself and Stefano. All right. Well, you guys are
What about
not having dinner with anybody
What
I know.
about the concept
Wait a
of
minute, that's unfair.
shooting
Not
for
really.
a
Bullshit.
neutral mechanical alignment, but potentially not chasing down the tight medial side to make the gaps perfectly equal?
So not balancing your knee? Is that what you mean? Or
Yeah, not
okay,
balancing
who doesn't
your
balance their knee?
perfectly.
I
mean, it's a good concept, right? I mean,
I get it. Look at.
you-
I mean, I know
right?
exactly where you're going. There's a point in time where you're chasing it a bit. It's still a little bit tight on the medial side. When do you stop? Right? And
Yeah.
that's a gestalt thing. And I don't know what everybody else feels here, but if I put a spacer block in, I still do spacer block trials before I've done all my cuts. And if I put the thing in flexion and extension, if it's not pinching enough and gapping open on the lateral side, even though it might rotate and feel a little tighter on the medial side, I'm done. Like, I don't chase that to the nth degree. But if you put your blocks in or your trials, and you can see an extension or flexion that's actually gapping, i.e. on the lateral side because it's pinching medially, likely something has to be done. I'll get right to you. Anybody cement balance. So when they get close, and they're like, I'm not going to put that distal femur all the way down, I'm just going to put it in extension and let that cement balance a little bit. Anybody here do it? No?
No.
Oh, you guys should do it. It works great, actually.
You didn't, I do.
It does. It's a great technique.
I do.
Yeah, I think people don't talk about it. I don't know why. That does your what?
Well, just cut more bone and just have it perfectly aligned. I mean, just cut a little bone medially, and you have to worry about your cement. It'll work.
Yeah, because I actually don't believe in I don't believe in the concept on the tibial side that that's a good idea. On the femur, I don't stress about the femur as much with that surface area.
But
You got to use a mic if you're gonna. I can't hear you. Oh, you're gonna get up? Oh, that's unfortunate. All right, no, come on up. I'm just teasing. I'm teasing you. Go ahead.
So I'm fortunate enough to have a robot. So when I'm making my plan pre-op, when I register all the data, and I go to, I take the knee through a stress range of motion, and I'm doing my thinking for balancing the knee. I'll sometimes dial in a degree or possibly 2 on the femur, which is kind of nice to be able to do.
Yeah. So if you're navigating, you can do the nuances. I mean, I think without it is pretty tough. But anyways, we'll keep going. There's no absolute right. So no one's using a drain, are they anymore? Anybody in the audience still using a drain? Okay. Revisions?
Occasionally.
Yeah, we don't use them. Like we don't have drains anymore. I don't think. Tourniquet. So this part's become. I don't know why this has become controversial. I think you got to be smoking. I guess you can smoke anything nowadays legally, especially in Canada. But anybody here not use a tourniquet? Who does not use a tourniquet routinely in their knees? Routinely. Yeah, at all. Okay.
0.
And then who just puts it up for cementing? Okay. And then who puts it up till the end, like the beginning all the way to the end? Well, it's split. I mean, the audience is pretty split. Is there something in between you? Something different?
Right,
Drop it
you
just
missed
before your
us.
closure.
Drop it before closing.
Yeah, I think
for-
that's important. You gotta control that bleeding.
Right.
Why?
Well, no, that's absolutely not true what you said. But
Just don't use a tourniquet, and you control the bleeding for the whole case.
there's multiple randomized trials that show it doesn't make a difference in terms of your ultimate
makes me feel better.
discharge hemoglobin. Oh, that's okay. We do lots of stuff to make ourselves feel better. I totally concede that point. The only thing we've seen now is the literature that perhaps that first day or two they have a little bit less thigh. I use a tourniquet from beginning of the case to when they leave the front door of the hospital, just so I don't see any bleeding ever. But always deflated before they go home. No, I mean it's all over the map in terms of the literature. So I think it's becoming quite very selected by surgeons. So what do? You
I don't use a tourniquet at all. I
Okay.
put one on for safety reasons. I don't inflate it. 0. Even when I'm cementing, maybe in 10 years I'll regret that when all my knees are failing. But right now, I think there's actually some pretty good literature out there showing quicker recovery, quicker quadriceps recovery.
There's some papers that show it, but I know the literature works. I just debated this.
Yeah.
And there's randomized trials that show no difference, and there's randomized trials like Doug Dennis's that show a difference. So,
Yeah.
But I'm telling you, you can defend both positions with
Sure.
randomized trials. It's one of those mixed ones, honestly.
One thing we didn't talk about is one of the reasons I do it is because I think it takes less time. You don't have to go,
less time
takes
with it?
less time because you don't have to go after all the bleeders and things, and so I can do it more quickly. I believe.
Well, I honestly, every trial has shown literally that the time is longer without a tourniquet, but in the neighborhood of about 5 minutes, because you actually do see the bleeders and you're going to. So it almost becomes a moot point. If you keep it up the entire time,
Yeah.
that's going to be the fastest, right? 'Cause
That's what I'm doing. That's
yeah,
why I do it.
I got it.
For the time.
All right, DVT prophylaxis, just don't think we have to talk about that. Tranexamic, that's kind of boring. So, all right, gap, what's that? Oral, yeah, that's a good question. So the route, we've always used IV. The Rush group published on using it oral. Anybody using oral tranexamic? It's interesting. It's by far the cheapest path to it, and the efficacy apparently is the same as IV. So I'm surprised in the U.S. and some of the bundles you aren't looking at that. Tad, what do you think about that?
I believe that it works, but my hesitancy is that we're giving these patients just mouthfuls of pills at the beginning now, and it just how much can they tolerate, and then what happens when it's mixed in the GI tract? I don't know. Maybe it's an unfounded concern, but that's the rationale for right now.
Okay. They've now raised the price of oral? Really? They're huge pills. Okay, well then there you go. I mean, we've not switched to it. It was intriguing when it was cheaper, but if it's almost the same price as a horse pill, no thanks then. All right, so gap versus measured resection. Who in the audience who's a measured resection surgeon? Really? All the rest of you are gap balancers that you set. And don't say you're in between because that's nonsense. So you do one or the other. And the reason I'm saying it, the concept of gap balancing is simply you do your tibial cut and you're going to set your femoral component rotation based on a symmetrical flexion gap. That's really the true gap balancing. So that's how people do it. Show of hands who does it that way. All right, and who is more, takes a jig, puts it on the femur, cuts the tibia, and then balances the knee? Who does it that way? Yeah, so that's measured resection. So here, what do you guys do and why?
I do measure resection because everyone else at my hospital was a gap balancer and the residents needed to learn another way of doing surgery.
Okay, Tom?
I like to mix it now.
So by your definition, I'd be doing measured resection.
Yeah. Okay. Well, it's interesting because most guys on the podium will then say, I do a bit of both. And really, if you understand the concept of what gap balancing is, it really is setting your femoral rotation based on a symmetrical, and I do not do that. Like, I do not change my femoral component rotation based on a flexion gap. So, all right, addressing a fixed flexion contracture, when do you begin, or do you ever, at the beginning of a case, go in and resect additional distal femur? Do you have if somebody's at 20 degree, 25 degree, 15 degree, or do you never do it and then just balance and redo it at the end? So start with that end.
If it is 20 degrees, I'll definitely take off a couple more millimeters
Okay,
of distal
so 20?
bone. I probably, depending on how rigid it is, I might do it at 10 or 15,
Okay.
but I will almost always do it at 20.
And would you only ever just do 2 and then that's it to begin with? Or do you
That's
ever,
what I always start with.
Yeah.
I can't say that
No, and I'm not
there are
saying
times
and
when
with
I
it. You
do
balance
more,
the knee,
but
but-
that's when I start with 2, for sure.
you start with 2, all right? And you,
Very, very rarely will I take additional distal femur initially. I think underappreciated joint line elevation changes can really affect the function of the knee. So I am much more aggressive about my posterior work. And then if I absolutely have to at the end, then I may.
so
But
you're sort
very
of a purist.
rarely at
You'll
the
do all
beginning.
the cuts, do all the osteophyte removal, release the posterior capsule, take it off the femur, blah, 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 blah. And at the end of the day, you've done all that. You're like, crumb, I'm still 10 degrees off. Then you do your distal femur. Is that
Yes.
okay? And Tom, what do you do?
Same, except, I was trained in the rule of 1/3, right? So if they started at 30, you got them down to minus 10, they'd work it out. Some don't. So I'm going to get them to full extension, but I'm not going to start on the bone side. I'll do the osteophytes, releases, et cetera.
Okay. Show of hands in the audience, how many routinely use antibiotic cement when doing your total knee? Show of hands up. And how many are selective for the high-risk patient only? And how many, anybody never? No. What? Okay.
Who trained him?
All right.
Who trained him?
That's it.
Who trained Eric?
I thought you said who invited him. He's
No.
the course chair. What do you mean who
I said
invited him?
who trained him.
Gets to say whatever he wants. All right. So why do you not do it ever? Because I think maybe other people do it, but you're the only one that had the guts to put your hand up.
Yeah. So I think there's a couple. I don't think studies are convincing to me one way or the other, particularly, although I do, part of this is from training in the sense that I got sort of some antibiotic stewardship drilled into me from Dr. Parvizi.
Okay.
And his points were always, when we were talking about this as fellows, was that it probably doesn't make that much of a difference, but it may select for resistant organisms if it does make a difference. The other thing I worry about a little bit is I do worry about its effect on the mechanical properties of the cement. And so I don't think it makes enough of a difference for me to use it. Now, I will use it on revisions.
Sure. So it's interesting. The literature, like a lot of topics, you can get papers to defend one way or the other. There's very compelling registry data, a publication by a guy named Jamson 8-9 years ago now, very clearly showed an association in knees, reducing the infection rate if you use antibiotic cement. Other registries have failed to show it. One of the challenges with registries is that when you do it in a big patient population, people are using it either routinely, never, or in high-risk patients. And so then how do you then start teasing out the real true infection rate in antibiotic cement or not when you've got a mixed bag of who's getting it? So, and the cost for you is quite a bit more, I think, than certainly for me. My antibiotic cement pre-mixed is only $100 more than my non-antibiotic cement. So it's not what's that? You're the same? Oh, so I thought it was more.
Is anyone mixing their own antibiotics into the cement?
Anybody doing their own antibiotics? One guy at the back there.
That's a lot cheaper. And
That
it's
is the
actually
cheapest
probably
way.
better because then we can put a cephalosporin in or something like that as opposed to Gent or Tobra,
Yeah.
which isn't great for skin organisms.
Well, we don't know, theoretically, yeah, we just don't, there's no evidence for that at the moment, as you know. The mechanical properties, honestly, that one I think that's a fake news deal because there's lots of registry data on hips and knees with the exact same, similar or slightly lower loosening rates if you use antibiotic cement. And the thought is that there's some undiagnosed infections that we're kind of not picking up, right? So
Yeah, I'd like to add to that because we did a Kaiser Registry study with 50,000 total joints. We saw a higher revision rate with high viscosity cement than low viscosity cement.
Right.
And
type of
so
cement
that
makes a
was
difference.
definitely there in a long-term study at 10 years. The reasons haven't been fully elucidated.
sure.
But
Tad?
Yeah, I think it's worth diving just quickly into the solution characteristics because as it relates to skin flora or selecting resistance, when you use an antibiotic-loaded cement off the shelf, what you get is a bolus release that's pretty much gone after 18 hours. And it's a high bolus release that's above the MIC of almost any organism. So it may not be the best directed antibiotic, gentamicin in this case, but it's at a high enough dose that it's going to have an impact. And then it's not going to hang around and be selecting resistant organisms. So that's why I don't have heartburn about using it.
Who, if you were going to have your own knee done on Monday, who would prefer the surgeon use antibiotic cement in their own total knee? Show of hands. And who would not care? A lot of self-haters out there. Okay, so let's get on to a case. So 55-year-old woman comes in with bilateral knee pain. Okay? So you see that importance of getting an actual a bit of a flexion view there, that you see the difference. So bilateral pain, 55. Audience, how many are doing some bilateral total knees? Show of hands. And how many are philosophically opposed and never do them? Couple? Okay. Thoughts? Anybody want to, what are your 2 cents on bilateral knees? Tom, and Mike ready?
The only reason I do it is flexion contracture.
Okay.
So if they've got a 25 degree or more, and I'm making the number, it could be 20.
Right, sure.
But I just figure you're not going to be able to ambulate post-surgery. Those are the ones I'll consider, or massive valgus or varus deformities. So it's all
Based on
angular
but
deformity.
someone,
That's it.
some guy comes in, run-of-the-mill, healthy, late 50s.
Oh, sure, they have to have all that. Right.
What? No, I'm saying, but there's no, they just got OA, medial compartment OA, you're going to do a total knee,
No.
but it's bilateral equal, but they're healthy. You're like, no, you got to do
No.
them, what, 3 months apart?
I'm gone to 4 months now.
4 months?
Yeah.
Okay. You guys, anybody different? You don't do bilaterals either?
No, I do.
Oh.
I do. I try to talk patients out of it. I really tell them how hard the recovery is. But for the right patient, healthy, has to be under the age of 75, I'll do simultaneous bilateral.
I would say the one thing that changed for me was the design of the instrumentation, because originally when I was first in practice, they didn't have the slots in the femoral rod, and there was a high incidence of fat emboli in bilaterals, and then they put those slots in and it went away. So
Got it. I mean, we certainly do our fair share of them. I mean, it'd be single-digit %, but we're not like going crazy. Young, healthy. The main thing is screening these patients, and there's good data, big studies that show the overall mortality is not higher. However, it's got to be pre-screened patients. You know, you got to really make sure they don't have any underlying cardiac issues, and that's where the age thing just becomes a surrogate to that. Like come on, you're in your 70s. Come on, we'll come back in 3 or 4 months. So let's say the patient comes in. I don't know if you guys get this a fair bit. Patients saying they've got metal allergy, not a fair bit, but every now and then someone comes in and they're convinced they've got a metal allergy. All right. Whether or not they've had testing or not, doesn't really matter to me, because they're convinced they've got a metal allergy. How do you approach that patient? Start at the end. Tom, what do you do?
I had one medical legal case along this line, so I'm a little more sensitive in this
You want to
regard.
pass on it then? Or you?
Yeah, no, it's fine. I mean, it was settled long ago, but it's problematic. I mean, I think that I would prefer. I don't think there's good evidence for the metal allergy issue,
Right.
And so I would prefer to use a standard component and standard implants. But I've been pressured because of the lawsuit more to using, the oxinium type implants.
So if someone came in tomorrow, and it's it's usually women that are they're convinced that they're allergic to metal. Is your go-to going to be using an oxinium component? This
If they are
they're
absolutely
convinced.
sure that they have an
Well,
allergy,
they're not
they're
sure, but they're
about it.
convinced. Who's ever
So,
sure? Like really, I
It's
mean,
documented in the chart.
Unfortunately, where I work is where it all started.
It is.
So
You got some
Karen
crazoid up
Pacheco
there.
is like down the street,
She's
and
nuts.
not only does she tell people they have metal and cement allergies, but she actually writes out an op plan and the patient has it for you. So, you know, which components to use and everything.
You hear about this? This is crazy. This is the Denver deal, because Doug
Yeah.
Dennis has told me about the same thing. and
It's
he
real.
bemoans the whole thing, and she's, exactly, you're allergic to this metal, you're allergic to this part of the cement, it's this. It's just, it's kind of crazy time. Anyways, so what do you do with that?
It's real. I think our ability to test for it is not very good, whether it's patch testing or lymphocyte transformation tests. We don't really know, you know, the accuracy of that, but it is real. I have a personal patient that was the daughter of one of the board members of the hospital that had an allergy to cement.
Okay?
One
What do you do is what I'm asking, though? Even if you believe it, so what do you do?
if I believe it, so I'll use an oxinium. I'll use a hypoallergenic knee.
Well, if they're allergic to cement, what do you do?
Cement
And metal.
and metal.
Yeah,
So this lady,
that's what you're implying.
So
is-
yeah.
So what do
So
you
I
do then?
actually had to revise the knee that I had put in about a year previous, and I went to a cementless, large diaphyseal engaging stemmed construct, and then I limped her through the 7 months of tibial pain that she had from the 18 millimeter stem I put down it.
So they don't make a cementless oxinium, do they?
No,
So
there's
what
no.
do you do on the femur side then?
The femur was stemmed as well. Yeah. I used the
know
biggest
what you
stems
would
that I
do.
could
So-
possibly get into the bone, and that's what's providing the fixation. Yeah. Stemmed, no cement, anywhere. And she's 4
What are you
years
going to do
out
when
now.
that fails? Like tomorrow? Okay, we'll move on.
Sure.
All right.
But, okay.
It's
so-
a bad situation. It's
is.
terrible.
So there's a completely other way of looking at this. You're not obligated to operate on this person, right? So
Right.
if I like them, I'll send leukocyte transformation and see what happens. If I don't like them, lucky enough, there's a guy in town who trained with Ed McPherson. He'll use, whatever component, and I ask him to take a look at her. And I'm not going to change my component. That's the point. I'm going to do what I want to do. So I won't put in a component I use once every 4 years for this patient, because I already have a 20% chance she's not going to like the knee anyway, regardless of the allergy. I've lost.
Right. Well, I guess my point was we can't just ignore it. I mean, a patient comes in, we have to somehow address it. We can try and, in some sense, talk them out of it if if we're convinced they're not real. But at the end of the day, once they're convinced, I think you need to listen to them and you need to do something. I mean, there's no point, to me, there's no point in they come and they're convinced. I'm not going to sit and try and convince them otherwise, right? So
Right.
unless they, especially because look, you've got some of them have come in with a bunch of tests. I mean,
Yeah.
you're obligated to listen to what they're saying, I think, and say, okay, this is the alternative. Doesn't mean you have to do it. If you want to send it to someone, that's okay. But I would not go ahead and forge ahead and do a regular total knee, because that is just asking for trouble. That's just asking for trouble. All right, so 61-year-old male, let's say a decade ago, had bilateral HDOs, and comes, both knees hurt, but the left one's hurting the most. Okay? So, what are your thoughts? Tom?
Here or
We
there?
only had one more Tom on the panel.
Is there a
Great.
couple more times? Yeah.
Tom B? No, it doesn't work either.
I would prefer to do a total knee. I mean, somebody would do some unis in this, but I would prefer to do a total knee and take out whatever hardware I needed to take out. It looks like you might be able to skate by it, but at least get those screws out of there, the top ones.
Top screws, leave the bottom screws and the plate in.
Yeah, I wouldn't take out the rest if I didn't have to.
Okay, and if it's in the way, and you take it out, do you think you need to stem that tibia or not?
No,
No.
not at all.
Anybody in the audience think they need to stem these? Good. Yeah.
And
They can't. Well, you're going to see it in a second. Yeah, so you probably can't hear at the back, but this particular plate does leave a nice big rectangular gap right where you see that we've converted a bunch, right? Because the Fowler Kennedy guy, we've just got a huge experience of converting HDOs, and we've gone through different iterations, but we don't stem any of them anymore. I mean, it's a massive gap, but routinely stem them, and we've had 0 fractures, honestly. We just haven't. So you're going to take out the hardware that's in the way, or is everybody going to take that whole plate out each and every time, Tom?
if they say, look, I press, it hurts,
Right.
I'll take it all out.
Exactly.
If not, it's just the proximal screws. I do think one thing, though, we don't have to deal with the opening wedge with Baja issues anymore, which has made this
Exactly what, yes.
easier to do than the old style lateral closing wedge
Everybody understand that? So look at that. Look at those lateral, yeah, both lateral x-rays. You can see old closing wedge osteotomies, and you still see some in your practice. Whoop, you've got this patella infer, and it's stuck down too. It's not, it's scarred in. You got to mobilize it. Most of the time, you don't get that anymore. And the slope issues that we used to see are generally not as significant either. So you've got those two things that we used to have to deal with all the time. You can see the slopes here are good. Because I've converted so many, I kind of now know, when you look at the lateral x-ray, also look to see how posterior the plate is, because the ones that are more anterior are easy enough from your arthrotomy, you're on the plate. Once they get more posterior, they can be a bit more of a challenge because you've got more of the MCL sort of over top of that plate. So that's another little trick. Just look at the lateral, and if they don't have pain, you may not want to go chasing that plate, quite frankly. Stem, no stem. So Mike, there's that's a little, you can see that little gap there on both sides. And that one had, I guess, a busted screw. I don't remember the case, but okay. So 71-year-old woman. Derek, just give me the sign. You want me to go to 10? Is it 10 after, or does it end up? What time does this one end, actually?
10 after.
10 after? Okay. All right. We'll go another 10 minutes. So 71-year-old woman, knee pain on the right side, progressive valgus. So this part of the history is relevant. Full active extension, but her patella seems to laterally dislocate, or is laterally dislocated, and you can't reduce it. So it's not like a subluxing back and forth. It seems to track laterally. That's what you're dealing with. So valgus measured about 30. There's her kneecap, not kind of where it's supposed to be. All right, so a little more challenging case now. So, Craig, why don't you take us through your thoughts on this one?
Yeah, so a couple things. Obviously, the deformity is going to be something you're going to be prepared to deal with. Start preoperatively telling her what her increased risk is for nerve-related issues, right. Especially with a fixed flexion and valgus contracture. So I would make sure to tell her about that. Her bone quality looks awful, so I think you're going to need to be prepared to have some extra fixation methods around. And then on the sunrise view, the patella being dislocated like that, that's going to be an issue, and I'd be prepared to do a full, like basically from lateral to medial, just full open lateral release.
But
Okay, and that's great about the warning them about the perineal nerve thing. It's not much we can do other than warn them, right? I mean, people have talked about going in and releasing it at the time, and that I would not be doing that. So you kind of just hope for the best.
Yeah.
Yeah, Tom?
well, this points out why a standing film is critical, right? Because I don't
I'm
know.
sure Derek you'd get a standing film. Somebody comes in with 30 degrees of valgus, anyways, right?
Okay, all right.
Yeah.
Because here you have to decide, am I going to be able to make a distal resection that does not affect the MCL, which obviously is potential,
Yeah.
at least
I
from what
hear
that
you're saying.
looks like.
Yeah.
Yeah.
But there's no real extra. There's that bow, but it's not a true extra-articular deformity, previous fracture. So I think you're going to be okay that way. But I hear you. You do your lines like you talked about before.
Right.
So take me through. So you do your initial cuts. You're tight on the lateral side, and we'll start with, say, flexion. Right. So put your blocks in, or you have a look at it, and you've done your cuts. You're happy. You've done your resection, but you're still quite tight on the lateral side in flexion. What's your move? What do you do, Tom?
Well, you obviously got to do the lateral releases, a full.
What though? What do you
releases.
release? You got instructions.
Everything you need to,
No,
just-
but what's your routine? Like this
Well-
happens Monday. What are you gonna? You just going to bovie everything?
Yeah,
or
I mean,
you
the
gonna-
other thing is be prepared, obviously, with stabilized implants and making sure you have everything there, which is.
If you're teaching your resident and they say, okay, what do I? I got a knife, and I got some white stuff.
Well,
What
you've got the full lateral release to start with. You're going to go down and release the pass.
I think he's pimping you, and he wants you to say the popliteus.
I know, yes.
I do want you to say the popliteus. That's all I wanted.
waiting on
I just wanted one word.
Waiting on that.
So there are people on the podium that say never release popliteus. You're going to go to hell. And then there's other people like me that know better, and you can release a popliteus in these really bad valgus knees, and they don't present with terrible rotational instability. So to me, that's a sort of an easy one. Absolutely, you can after do that if you really want to go lateral side of the tibia and start stripping things, and you can pie crust things. And I tend not to pie crust things that aren't a pie, but you can do that. There's different techniques that are described. Okay, if you're tight in extension on the lateral side only, what are you going to release there? What's your plan there, Tom?
I do like the pie crusting,
Of what,
the
though?
ITB.
IT. Okay. You guys pretty much
But I
agree with
will
that?
say,
Yeah.
in all fairness,
Uh-huh.
by the time I'm done, It looks like somebody threw the pie at the wall. I mean, it's just shredded.
Well, it
I
only
can't
works
make it
once you
look
connect
pretty.
all the pie crust things. I mean,
Right.
look, you really think the IT band, like, anybody,
I just release it.
yeah, I
I
get
take
you.
the bovie, it's tight, I start cutting until there's no more tight.
I mean, the IT band, you know, it's going to be a structure about that big, and you can pie crust it and try and stretch it. But I've yet to see a video of somebody showing me that it actually truly does miraculously stay intact and stretch. Usually you keep doing it until you've connected all those dots and the thing's released, and then, oh, look, it's imbalanced. So that's just my 2 cents.
My only other tip, when I'm doing a lateral release, I always have my scrub hold the foot when I'm working with bovie.
Okay. I use a knife, but you use Bobby.
Yeah.
We talk about, oh yeah, so how about, what's your tricks on the femoral component rotation in these valgus knees? Well, what do you have to be aware of, Greg? What's a common error if we don't think about it?
Well, I mean,
Internal
people
rotation.
always talk about the hypoplastic lateral condyle. I think semantically, I call it's worn out. You know, I don't think her lateral condyle was hypoplastic since birth. This isn't a congenital issue, but it's worn out. So, yeah, technically, you got to be very careful on your rotation of your femur. If you're a posterior referencing person and they have a lot of wear on the posterior lateral condyle, it's going to air you into internal rotation.
So I don't gap bounce. Anybody who truly gap bounce, you've done your tibial cut, are you going to allow your femoral component to internally rotate in the valgus knee in order to free up that lateral side? Who gap balances as their primary technique? So Tad, what do you do? What do you do in the valgus knee then? So you do your tibial cut. How do you know when to release things and not, and whether just to dial in rotation, or do you have in your mind, I'm only going to accept neutral rotation, or how do you take me through your thoughts?
Well, this is one, I think this situation and the case with the huge posterior osteophytes where you've got to be careful about your balancing and you don't want to get led astray. But so to answer your question, in workflow, what I'm going to do is do distal femur, proximal tibia, and then I'm going to try to balance the knee in extension, see if I can get a rectangular extension gap. And then I'm also going to check the knee inflection. I'm going to bend it with a spacer in there before I make any cuts and see what's going on. And if you truly have an incompetent MCL and it just opens up, then you really cannot rely on a ligament balancer and flexion. And you have to think about your other anatomic landmarks, whatever you want to use, the transepicondylar axis, something that puts the femur in a reasonable rotation, and think about increasing constraint. So this is a situation where you've got a flexion, extension, imbalance. You can't actually balance it because you've got incompetent ligament on the medial side. So I'm going to go up in constraint and look at my anatomic landmarks for rotation.
Okay. So show of hands, who would go in plan A PS knee? Show of hands. CR? Mike? Who would be constrained? Plan A is constrained. So it's 50-50 almost, a little bit more plan A PS. And so Craig, to your point, I did do a little bit additional fixation on the femur because the bone was pretty crappy actually. I do remember it's kind of mushy, so I don't think even today, this was done a few years back. I mean, you could maybe add metaphyseal fixation, but the bone stock's pretty horrible. So I think in a low elderly demand patient, a shortish somatostem makes some sense.
Go back and just describe your cement technique on the femur.
Yeah. So when you cement, I put in like a cement restrictor. I go through the whole thing. Cement restrictor, pulse lavage, pressurize the canal, have glue on the femur, put it in. Thanks. Good point, Mike. So.
Did you do anything special to get the patella to look that good? Patella is dislocated on this one.
Oh yeah, I forgot about that part of the case. Yeah, no, just exceedingly good skill. So the two things that you talked about, lateral retinacular release, so that was done. And then I don't know if you guys ever do the technique of sort of over-reefing on the medial side. So instead of just closing your arthrotomy, you sort of over-reef it. I did it on this case. So those are the two things that I did. Obviously it worked, and that's not her skyline because hers is dislocated, but I put that one in there. All right, so we haven't really talked much about obesity, have we? No. So who here works in an institution where they have a cutoff? Nobody. Oh, one. Okay. Who has their own cutoffs? Who has a number? Okay. The cutoff. Who has a cutoff of over 40? Over 45. Okay. Who has no cutoff? Based on a number. Wow. So most people have a cutoff. Guys, I'm 100. Anybody over 100,
BMI 100?
We're not going to do. No, we don't have a cutoff, and where I work, we just get all these things dumped on us. And I get that. Like, I don't expect guys in the community who have one assist, who may or may not be that great, to be doing these cases, because these are tough cases, right? I have a resident and a fellow, and I'm sort of spoiled. So, but we don't have a true number cutoff where we won't see the patient. Doesn't mean you don't counsel them, you don't talk about weight loss, you do all that stuff, but you just won't see the patient at all. There's lots of places that you can't get in the door to even talk to somebody. So go ahead, Tom.
Yeah, we talked about this last night at dinner, actually. We were talking about what you don't want to do is have a firm cutoff and just tell the patients, there's no chance for you to go and find something else. You got to keep connected with them. So what I do is I give them a target weight and say, I want you to get to that weight, and every 3 months, send me a message, tell me where you are so that we can track where they're going. And if they're not going anywhere, we're not going to do it.
Okay.
But I'm not responsible for the weight loss. I send them to somebody else to do the weight loss.
Who's this somebody
Primary
else?
care is
Okay,
gonna
so you send them back to
coordinate.
family doc. It's surprising how many, so I sit and talk to them, and it's surprising how many family doctors, maybe it's Canada, don't really have a lot of conversation with patients about
Oh, it's
obesity.
same here.
They treat their diabetes, they treat their hypertension, but to have somebody actually sit and say, you know what, look, you have sleep apnea because you weigh 295 pounds, not because all of a sudden you can't breathe at night. Like it does take time. So here's what we do. I had to buy a scale because the scale at my clinic was only accurate to 300. It's now a digital readout and it's accurate to 800. So we weigh them. That's what we do. We weigh them. We put that number in the chart. I come back 6 months. I hand them a book with a title of this diet that's just a regular, not crazy diet. I give them that. So you go to the bookstore, buy this thing. But some patients you can't operate because of their size. Some you can.
Right.
A lot, it's just going to be annoying, but you can get through the surgery safely.
Why?
Why what?
Why do we have to operate on these
I didn't say
people?
we have to.
No, that's what everyone's saying, is that we're jerks if we have a cutoff and it's our Hippocratic oath to operate on every person that comes in that looks like that. I would argue that all this stuff we talked about with financial cost and this and this and this, I mean, we could probably cut a lot of cost out of the system by just eliminating stuff like that, right?
Well,
Well, I think that approach,
wait a minute.
that would be being a jerk because,
Wait a minute.
well, you know, I am going to call you one. I didn't call you one before, but, so what's the risk? What's the risk? Let's take me through the math. So you operate on a person with a BMI of over 40, their risk of infections 2 to 3 times higher.
Yeah.
It's not, so that means, you know, let's say it's 2, 3, 4%, meaning 96% of them or 97% of them are not going to get infected. So we take patients on that are skinny and other risk factors, and we do it willingly when we know it. So we sort of pick obesity because it's a real pain in our butts to do the cases. So I would say to you, there is a role for it. I'm not saying everybody should do it, but I think to say, and you live in the thinnest state in the country, right, don't you?
Yeah, we don't have any patients like that, but I was just trying to be controversial here. I mean,
Your average BMI is like 12 or something in your series, so usually you publish.
no, I mean, I don't think that we need to be forced into doing things.
No, you shouldn't be forced in.
And in an academic center, you're right. You know, we get all of this, right? It's easy for the private practice surgeon to say, I'm sorry, our OR bed's not big enough to hold you, but go over to the university and they'll do it. Especially, you know, when hospital compare, physician compare, and things like that are coming out, and consumers are more educated on their choices, but they don't know that my infection rate is 5% because I have 50 of those patients.
Yeah, and that's a much
running
more
around, right?
complex issue, right? That's not no risk adjustment in publicly available data. We do have the same issue. We have the exact same issue at our institution. Tom?
There are lots of modifiable risk factors, and obesity is one of them. Smoking, hepatitis C treatment, those kinds of things, you have to minimize those, but it doesn't mean that you're going to set a rigid cutoff for all of them.
No, but I mean, if
try to
somebody,
say
if
that
somebody's
they stop
rheumatoid,
smoking, but
yeah, but I got it. But if someone's rheumatoid on a bunch of, you know, methotrexate and other things, and their infection rate is 2 or 3%, we're going to do those cases. You got an obese patient who's got a risk of 2 to 3%. We're not going to do those cases. Why's the difference? It ain't because of infection. It's because that's harder to do than a thin rheumatoid. That?
Yeah, this Tom said the word modifiable risk factor, and that's kind of a buzzword. Everybody's using it. It sounds pretty great. Let's modify the risk factors. And some of them, like if you stop smoking, we know, okay, well, that will change things. Obesity is one where it doesn't, where they can have the obesity operation, they can lose 100 pounds. They're still catabolic, and they still have a high risk of complications. So it doesn't go away. And I bring it up just because we get sort of hung out there on whether we've modified the risk factors, and it's a process measure, but it's not hooked to outcome. And so we need to push back on that a little bit sometimes.
Great.
So for me, it's always the same conversation after the physical exam. Look at their BMI and let them know that there's two issues here. One is your medical comorbidity risks, which are going to be higher, and then it's, can I technically do your surgery safely? And I always give them, here's a target weight. And I say, you do need to try a diet program. I see them back in 4 months. If they're losing weight and they want to keep losing weight, great. But I tell them if I can technically do it at their weight, in 4 months, I will.
Okay.
So that's what I do.
So different approach. I think probably that's time, Derek, is it? Good. Okay, thanks,
And the
guys.
correct
That was good.
Thanks.
Thanks.